Good morning and welcome to the May education session for the Coding Corner. Today's presentation is going to be over one visit or two. We're going to be speaking on preventive services, annual wellness visits for Medicare patients, as well as office E&M services, when it is appropriate to bill one service versus both services. So let's go ahead and get on into today's agenda. So we're going to be covering when is it appropriate to bill only the wellness or preventive visits, billing your new versus established E&M office visits with preventive or wellness services, billing your, this is both your low level and your moderate level visits, and then when is it appropriate to only report your regular E&M office visit services. So, a little bit of overview. So, in a lot of cases, we see either a low or a moderate level billed. So, you have the option if this is a new patient, you would bill your 99203. If it is a moderate level, 99204 or 214. So it really depends on whether the patient is new or established with your practice, and when is it appropriate to bill these with our Medicare wellness visits or our preventive medicine services. So Medicare wellness visits or annual wellness visits are much more stringent in the requirements for the provider's documentation, specifically when you are trying to bill this or your provider is trying to bill this with a office E&M service alongside. So we're really going to kind of deep dive into when is it appropriate for this provider to bill both services, and when is it really more appropriate for them to only be billing the service that the documentation supports when it's only one or the other. Because let's be honest, there are certain situations where both are warranted based on the provider's documentation. And there are some times where they may have the intention of having this patient come in as a wellness visit, but they're very, very sick. There may be an exacerbation of an issue. And in those cases, it may be more appropriate to bill this only as an office E&M service. And just on a side note, I really would like to get into the idea of if that patient is truly sick enough to justify a high level of medical decision making, it's unlikely that it really supports a wellness or a preventive medicine service. If they are that sick, there may be an instance where that patient needs to go on to the ER to have those exacerbation of symptoms or new life-threatening symptoms further reviewed at the hospital. Okay, so let's talk a little bit about patient status or medical history. So typically, when you are looking at a preventive or a wellness visit or annual wellness visit, if you're more comfortable with that saying for Medicare wellness services, what we're really looking at from the patient status, they're coming in only to have that preventive service. They are in good health. They may have chronic issues, but they're not having any exacerbation of those issues. They're not having a NODIC goal at this time. They are presenting for today's preventive service in good health with no other issues needing to be addressed for today's visit. So let's talk a little bit about the difference between a stable chronic illness and a chronic illness either not at goal or exacerbated, or even in certain instances, severely exacerbated. So when we talk about a stable chronic illness, we're talking about an illness that is in a good range, whether that be based on the provider's opinion, is that based on lab work, is that based on other testing? And remember that stable chronic doesn't mean that this patient no longer needs medication or whatever the case may be. They're still probably on a medication for that chronic illness, whether that be like hypertension or congestive heart failure, diabetes, etc. But we are not addressing specific chronic illnesses that need changes in medications, whether that be increasing the dosage, lowering the dosage. This patient is in stable condition. So it's at goal, is what we like to call it. They're not having an exacerbation of symptoms, meaning that if they have hypertension, it's within a stable range. It's not elevated or low based on that provider's opinion or standard. So, what we really want to focus on is, why are they here today? If they are coming in today for that preventive or wellness service only, and we're not seeing any of the previous issues that I just discussed, then that's what we need to bill for today. Sometimes I think there is a confusion with providers and or coders where in some instances they're refilling prescriptions or changing prescription. If you could please make sure you mute yourself, I would greatly appreciate it. Um, So just remember what they are there for today. We need to make sure that we educate our providers appropriately to know when it is appropriate to only bill that annual wellness service or that preventive service and not bill the office or other E&M service. So let's talk about some of the HPI examples. So patient is well, has no complaints. That means that there are no other issues they're wanting to talk about today, whether that be a new issue or a chronic issue that is ongoing. The patient needs prescription refills, but they're not needing to be addressed as far as increasing, decreasing, or being taken off those medications, which requires additional medical decision making from the provider's perspective. They may have chronic illnesses, and a lot of times, especially in our Medicare patients, they may have multiple chronic illnesses, but we're only going over the bare minimum. We're only talking about them as in we're addressing that they exist, we're refilling medications when it is necessary, and that there's really no other medical decision making taking place outside the preventive or annual wellness requirements. Okay, so the exam. When you see the exam, you're looking to see, is there anything out of that normal range? If the provider documents the exam and they're telling you all of these areas that they looked at today, which remember in 2023, originally 2021, but finalized in 2023, the exam is to the extent that the provider feels is necessary for today's visit. So, if the provider documents that everything looks normal, there's no change from previous exams, then we know that there's no other concerns, whether it be from the patient's perspective or from the provider's perspective. Also, this is going to flow into the assessment and plan. So remember, they're not changing any treatment on any of these chronic or even acute symptoms the patient may be having. They're Everything looks good. They're scheduling normal screenings, whether that be a colon screening, a mammogram, normal scheduled blood work if they need to do immunizations. So in some younger people, that may be just a flu shot, but in maybe older people, that might be the in some cases the RSV for elderly. That could be the Prevnar. That could be the high dose flu. Those are all elements of a either preventive or annual wellness visit. And that also includes only refilling prescriptions with no changes. So conditions are listed but not further evaluated or managed. So they're going to say that they have these chronic conditions or that they're reviewing to make sure that nothing else is going on, whether that be through lab testing or other radiologic services. But they're not having to increase their medical decision making to change or edit any of those conditions. So let's talk a little bit about our office E&M services. Right now, we're going to look at low medical decision making. So if you have a new patient, that's going to be your 99203. If you have an existing or established patient, that's going to be a 99213. And when it is appropriate to also bill those preventive and wellness services. So let's look at the patient's status or medical history. So they're coming in today not only for that preventive service, but they're having either an acute, uncomplicated illness at the time of the visit, whether that be, say, they feel like they have a UTI, or they think they're coming down with bronchitis or a sinus infection. That's what we would consider an acute uncomplicated. It runs its course, whether that be with medication or without medication, and it follows the line of once they get over that illness, it no longer follows them like a chronic condition would. That also could be an active, stable medical problem that they're coming in with that they're wanting to be further addressed. It could be a couple minor problems like just a runny nose or just a cough, um, things like that. That are very minor. They follow a normal course, and typically, with your minor problems, not even a medication might be involved. They may recommend like a saline rinse, or if it's another minor problem, like say a bug bite or something, they may tell them to use an over-the-counter steroid cream. Or if it's a minor pain, they may say use over-the-counter Tylenol or Advil or something of that nature. But it is not further advanced or further exacerbated. So remember that for these providers to bill both services, the provider must document significant additional work beyond the wellness visit requirements. So that means this is how I like to look at it. Other people may have other opinions or viewpoints on this, but if you were to erase everything related to that preventive visit, what would you have left? If the documentation that's left supports a significant separate visit beyond that wellness visit, then you can bill that office E&M service. So just think about that when you're doing your next code for preventive and E&M services. Think about it like if I was to take away everything related to this preventive service, is there enough documentation to support an additional office E&M service? And remember, when you're billing both services, you want to make sure that you're appending your modifier 25 to your office E&M service. Now, if there is a situation where you have a preventive service, an E&M service, and then you have, say, injections or other services that require a modifier 25 on the E&M service, you need to put the 25 modifier on both the preventive service and the E&M service. And that separates it from the other injections or other minor procedures that may have been billed on the same day. So let's talk a little bit more about the HPI versus exam findings for acute, uncomplicated, two minor problems, or the status of that existing chronic condition that's significantly reviewed. So remember, When we are talking about chronic conditions, I mentioned this earlier and I'll mention it again, that with a preventive only service, they are only listing that the patient has those chronic conditions. If this is a service where they are significantly reviewing that chronic condition and not just listing it. So the patient has been having elevated blood pressure readings. So they're coming in today for that preventive service, but they're telling the provider, hey, I've been checking my blood pressure and has been getting higher and higher. We're consistently at a higher number than what we previously discussed as a normal range. Or even they came in today and their blood pressure is raised to a considerable higher level than the provider would like. They may do a second check or even sometimes a third check, depending on how elevated that blood pressure is on that data service. So just remember when you're reviewing the documentation for these providers, how much detail, how much documentation is your provider giving you that would signify whether or not it was over and beyond what they would review for a preventive or wellness service. So, when we're talking about the exam findings, remember if it's normal or unchanged from previous exams, it's probably just going to be that preventive service. But there might be that unexpected abnormal finding that the provider or the patient may not have come in with, um, expecting to have an additional sign or symptom or an exacerbation of a chronic condition. So the provider's doing that exam and they find something that they don't like, whether it be that hypertension with the blood pressure being increased, or the patient might have congestive heart failure, and and the provider sees that the patient's lower limbs are swollen. They may be not releasing that fluid. And the patient didn't tell the provider this, they didn't acknowledge it originally, but the provider finds it in the exam itself and then has to use that extended medical decision making to decide whether are we going to put this patient on like Lasix or another medication that is a fluid medication to reduce this swelling in the lower limbs. So those are things you really need to look for when you are making the decision whether or not to bill both services or only one service. So, again, let's talk a little bit more about the assessment and plan. So, sometimes we're only seeing the order of the labs, which are just normal, reoccurring labs, say, a CBC. If they have diabetes, it may be an A1C, a glucose reading, whatever the case may be, but it's not out of the ordinary for a preventive service. They're refilling the existing medications, but they're not having to change the milligram or the type of medication. Usually the follow-up is 3 to 6 months or less. So if we're billing both services and this patient is having that new acute symptom or they are having that exacerbation of a chronic condition, they're not going to say, I'm going to see you in a year. Usually,
Mm.
depending on how bad it is, they might see them in 2 weeks if they add a new medication. They may see them in 3 months once they have finished the lab work, got the results back, and then maybe sent them for another test like an ultrasound or other diagnostic procedure, especially if that provider doesn't have access to, say, a CT or an MRI or a lower extremity ultrasound within their office. They have to schedule that out and then they have to wait so they can either read those or get the results from that radiologist so they can reread them and see the patient back within a certain period of time. But the main thing to keep in mind as far as follow up goes is, like I mentioned a minute ago, if a patient has a new symptom or an exacerbation of symptoms, it's not going to be like your traditional preventive or wellness service where they're only done once a year and they say, see you next year for that next service. So make sure you keep in mind that when you're reviewing these notes. So if there is a treatment for an acute problem, so they do feel like they're coming down with a sinus infection or a UTI because they've been having dysuria or trouble urinating or pain while urinating, and they're wanting to have a urinalysis done to see if they do in fact have that UTI. So that is additional treatment beyond a preventive service. Again, if you are not on mute, if you could please mute yourself. Um, so the provider must show the management when there is a chronic problem. So if they are telling them your blood pressure is elevated, we need to review this closer. So I'm going to bring you back for a blood pressure check in 2 weeks. I'm going to increase your blood pressure medicine by a certain milligram, and we're going to see if that's working well. I want you to come back. We're going to recheck your blood pressure. They may even have them do a like a notebook of checking their own at home, a little like blood pressure diary or something. So when they bring them back in 2 weeks or they bring them back in a month, they can see consistently, is it still elevated? Is it still low? Is the medication increase or lowering? Is it helping? Is it changing anything? So just remember that those are situations where the documentation may support that separately billable evaluation and management service. So now we're going to talk about the moderate levels. So this could be a new problem with uncertain prognosis. So when we say that, that means that it's not already a definitive diagnosis. They could be coming in with persistent headache, abdominal pain, um, back pain, something that the provider's not seen this patient for before, and they don't have a definitive diagnosis. That means they're going to have to do additional lab tests, additional diagnostic testing to figure out what's going on with this patient. They're concerned that they could have a bowel blockage if it was abdominal pain, or that they're having migraines and that's why they're having headaches, or it another concern where they don't know as soon as the patient comes in what the definitive diagnosis is. So they have to do that additional testing to find that definitive diagnosis. Or in some cases, they may have to send them to a specialist. So they'll put a referral in to, say, a endocrinologist or a general surgeon if they are concerned, say it's a bowel blockage or something. So just keep that in mind, or even a gastroenterologist if it's abdominal issues that they may feel is GI related. Then there's an acute complicated illness. So this might be something where the patient comes in with severe urinary symptoms. They have a UTI. They're going to send off that culture. The provider does blood work, and there are certain elements of that blood work that are much higher than it should be. And it might be systemic. So it might cause a fever, it might cause other issues that they're concerned about. So that's what we would consider an acute complicated illness. There's also the element that it could be an acute complicated injury. So the patient fell and that's why they're having back pain, and the provider feels that it's severe enough that they need to send them for an MRI or they need to send them for a CT scan. Those are what we consider advanced testing. It's not just an x-ray in the office, which is what we would consider simple testing. So if they feel that it's complicated enough that they need to send them somewhere else, they need to send them for that diagnostic procedure, that's when it becomes complicated versus uncomplicated. Also, is there a significant exacerbation of one or more chronic illnesses? So this isn't just they have the chronic illness and they are going above that preventive service for medical decision making. This is, let's keep on that hypertension. Okay. Let's say they're seeing numbers of like 180 over 100 or something significant, okay? Or they're having issues with exacerbation of two or more. So let's say their A1C doesn't look good or their glucose readings don't look good for their diabetes, and they're having hypertension issues, high or low, whatever the case may be. Okay, so just think about that. Are both of those illnesses, those chronic illnesses, being addressed over and beyond that preventive service? Again, like we mentioned earlier, they're scheduling a follow-up visit um, for a shorter period of time than they would for your traditional preventive service. Also, again, the provider must document that extra work. So if it falls into that low category, that's fine. You can bill that 213 separately. If it is two or more conditions that are exacerbated or acute complicated, and it justifies that additional work that meets the moderate E&M level. Okay, remember what I said earlier. In your mind, erase all the documentation that relates to that preventive service. And what do you have left? If what you have left meets a low level, then you can bill that 99213. If what you have left meets that moderate level, bill that 99214. But again, remember, if it is so severely exacerbated that it meets a high level, um, we probably no longer meet that preventive service because this patient is sick. This patient has a severe issue that has to be addressed. It's no longer a well check. Okay. Hopefully that makes sense. So, some HPI examples. Like I mentioned earlier, a new headache, they're having dizziness, abdominal pain, dyspnea on exertion. These are all what we would consider um, signs and symptoms with uncertain prognosis. Okay, this isn't a bug bite or a simple scrape on the knee or what you would consider a basic headache. This is something that is severe enough that they're wanting you to address it. The providers are doing that additional testing. Just remember that. Okay, that's a big argument amongst low versus moderate, is that uncomplicated versus complicated issue. Also, multiple stable chronic conditions that were significantly reviewed. So let's take a new issue. The patient has anxiety, but today they're telling you that they've been having um, multiple issues at work in regards to their anxiety. It's causing loss of sleep. It's causing them issues at home, expanding past just at work. That might be something that they need to review significantly to find out, is the medication they're on working? Do they need to send them to a psychiatrist or a psychologist or a licensed clinical social worker or something like that? That's significantly reviewed above and beyond just having a stable chronic illness. Okay. The provider needs to be reviewing those stable problems and describing the symptoms of why they're poorly controlled. Okay, we don't want to just see that the provider is documenting they have diabetes or they have hypertension or they have anxiety. What are they doing about them? If they're not significantly addressing them, it's still just a preventive visit. Okay, so again, are the exam findings normal or unchanged? Are there unexpected abnormal findings? Has the patient's physical condition deteriorated since their last visit? That's again what we would consider an exacerbation or not at goal. So when we say deteriorated, exacerbation, that could be an adverse effect of a medication, or the medication is no longer working as prescribed at the milligram, or the medicine itself is not working as planned, and they're having to increase the dosage, decrease the dosage, or change the medication altogether. So again, what are the changes to that treatment plan? Did they have to order x-rays, lab tests, not just screening tests, but additional lab or diagnostic testing beyond what we would consider screenings? Okay. Remember, I mentioned earlier, they're referring them to a consultant, whether that be like a gastroenterologist, an endocrinologist, um, general surgery, whatever they feel is appropriate for what they are addressing for that patient. Okay. They're reviewing that treatment plan for those multiple problems, even with no changes. If it's complex, if there's multiple medications, is there a moderate risk of morbidity? So let's talk about morbidity for a minute. Morbidity and mortality. The things that these providers have to think about is when we talk about morbidity or mortality, what is the likelihood that patient could die before their next visit? If there's a low risk for that, then it's probably going to fall into that low category. If there's a moderate risk, like if I don't up this medication, or I don't change this medication from a provider's perspective, and there's a higher risk, so let's say that moderate risk, that this patient's condition could significantly worsen without this change in plan. Okay, so that's what you need to be asking yourself when you're reviewing this provider's documentation. Okay, they need to be accurately documenting. Remember that, especially if you work in an office where you have the ability to query the provider, or you can educate your provider, I need to see this, this, and this to be able to substantiate billing this additional E&M service. Okay. And again, just as a side note, we've already talked about it, but scheduling in a shorter period of time for a follow-up versus I'll see you next year. So now we're going to talk about when does it support the E&M visit only. Now, I've mentioned to you previously about that high level. If it met that 205 or that 215, it's beyond what we consider a preventive service at that point. So, if you're looking at the patient's status or the medical history, this means that they're so acutely ill, or they have so many exacerbated chronic conditions. This provider doesn't have time to do the screenings and all this other, just what we would consider preventive work. Okay. This is well and beyond a wellness visit. In the HPI, they're having a severe increase in symptoms. And remember, this can be severe at an acute, meaning it came on suddenly, or this could be severe in the chronic sense, meaning it's continued to get worse over time since they saw their provider last. The exam is markedly abnormal. This means there are multiple areas or one severe area that calls out to this provider to increase that medical decision making that they must make. The assessment and plan. So, this point, they're going to reschedule that physical exam. We're not even going to get into that. We don't have time for a preventive service today. We must address this severity of acute or chronic issue. So they're ordering immediate diagnostic testing and they're going to closely follow up this patient. Remember that 2 week follow up. Or if it's severe, they may want to see them in 3 to 5 days because it's that severe. So let's talk a little bit about our Medicare wellness services. So if you're new to coding, you may not know that your G codes are like your annual wellness visit codes, but typically with your G codes, those are going to be your Medicare services. Whereas we're going to use the medicine section or the evaluation and management section for preventive or E&M services across the board. Now, that's not saying that your Medicare patients aren't still being billed your regular evaluation and management services, but specifically for preventive services. Medicare does not pay for those 90,000 series preventive services. They are paying for the G code services. So for your G0402, this is going to be that initial preventive exam. It's a face-to-face visit, and this can only be billed in the first year, first 12 months that patient was on Medicare. So if your provider misses that 12-month window, they're not going to be able to bill this, okay? So you need to make sure that if your practice, your provider's practice, or the um, um, providers you work under, if they have a large Medicare base of patients, they need to make sure that they're uh, utilizing the G0402 within that first 12 months that the patient moves to Medicare. So then we have what we consider our annual wellness visit services. Um, that are not just in that first 12 months that the patient moved to Medicare. So you have your G0438. So this also is only billed once in the patient's lifetime, but it does not have that requirement of the first 12 months. Okay. So the very first annual wellness visit that that patient has, your provider is going to bill the G0438. And then every year past that first service, they're going to bill the G0439. This is what we consider that annual wellness visit, okay? Yearly. One time a year, they're going to come in and see that provider. The provider is going to bill the G0439. I would also like to state that with any of these preventive services we're covering today, if you have never worked for a payer, or maybe you work in denials and you've seen this before, we need to make sure that the providers or the staff of the provider is scheduling these at least that year or a little past that year. Because even if it's a day, 2 days, a week ahead of that year, that payer is going to deny it. So you need to make sure that it's within or past that year, not previous to, for these annual visits. So this is a summary of what is required for annual wellness visits. I want you to keep in mind that the requirements from Medicare are much more stringent than a regular preventive service for anyone outside of Medicare patients. So I'm not going to go through all of these. I just want to call out a few major things. We need to make sure that we are seeing the providers documenting, are there any cognitive impairments? What is the person's state of mind? Are they a depression risk? Um, are they having any issues with getting around? Do they need a walker? Do they need a wheelchair? Do they need other assistive services um, to help them? Okay. They need to have a written screening in this patient's chart. Okay. Preferably within this encounter's visit, not something that has to be referred back to. Because again, if this makes it to the payer for a denial reason and they request those records, they're probably not going to request the entire medical record. They're going to request that day's visit, and it needs to be in that day's documentation. The provider's going to review any what we consider like high risk drugs to the elderly. So, for instance, with opioid medications specifically, those pose a greater risk to elderly people as far as fall risk and other negative impacts to the patient's condition because they're already having issues probably in some areas of disorientation. They may have dementia, Alzheimer's, or other conditions that opioids can only um, exacerbate. Okay. So those are just a few call outs. Social determinants of health are also something that has become to be so much more important over the years. So do they have access to get to their appointments? Do they have family that bring them? Do they have to call like a medical bus to pick them up? Do they have abilities to pay for their medications? Those are some of the social determinants that need to be looked at. Um, for annual wellness visits. So let's briefly go over preventive services. So these are going to be your code set between 99381 and 99397. Okay. So these are billed based on new or established and the age of the patient. So this starts at infancy through all the way through adulthood until the point that they move over to Medicare or when they move to Medicare. So again, your new patient initial visits are your 99381 through your 387. Your subsequent or established patients are your 99391 through your 99397. Remember, this reflects age and gender appropriate history, exam, and assessment and plan. So this is just a table. I'm not going to go through every section, but just remember that all of your preventive visits are based on newer established and their age. So as you can see, elderly patients can still be billed preventive services if they are not on Medicare. Once they move to Medicare, it moves to the annual wellness services and the G codes. So, a little bit more about new and established evaluation and management services. So, just remember this is a reminder for all of you all that are experienced in this area, or if you're new to this area, um, this is 3 years. So 99202 through 205 means they have not been seen by that provider or provider practice and specialty in 3 years. Established means they have seen that provider or practice and specialty in 3 years, and that's going to be your 99212 through your 215. Remember that for regular evaluation and management services, we now can bill based on time or medical decision making, and it's what's more advantageous to that provider. For those that may not know what advantageous means, that means it's whatever benefits the provider most. So if they document time and that time doesn't meet the same level that the medical decision making meets, then you want to bill whichever one benefits the provider the most. So if 60 minutes meets that higher level and the medical decision making documentation itself doesn't, you're going to bill based on time. If they document 30 minutes, but the medical decision making documentation itself supports that higher level, then you're going to bill that higher level. So just remember, brief overview. We're not going to go into excessive detail into the MDM table, but just remember that to bill that office E&M service or any regular E&M service, they must meet two of the three categories out of complexity of problems addressed, or we call that COPA, amount and or complexity of data reviewed, which we call data, and then the risk of complications and or morbidity or mortality of that patient, which we shorten to risk. Again, this is another table just outlining the types of medical decision making. The three sections are COPA, data, are risk. whether that patient is new or established, and if you're billing based on time, how many minutes must be met or exceeded. Um, a few years ago, these were based on a range of time. Now it is, for instance, for a straightforward visit, 15 minutes for a new patient must be met or exceeded. So if they spent 14 minutes, you can't bill based on time because they didn't meet the minimum time requirement. Hopefully that makes sense. So this is our MDM table. Like I said, we're not going into great detail on this. This is more for a visual only, that if you're billing these E&M services, that you're making sure that it's meeting two of the three categories or columns to bill that level. They may have a high COPA, but the provider didn't order enough testing to meet the data, or they didn't order that RX management, or they didn't make a decision for surgery that put them at a higher level. They still have to meet two of the three categories to meet that full level. Okay. So that concludes today's presentation. Here are the resources used to create today's presentation. I really appreciate everyone for attending today. If you're listening to this on the replay on YouTube, I would greatly appreciate a like and a follow over there. And remember that we have the Facebook page and the YouTube channel, as well as I'm over on LinkedIn if you would like to connect. So again, thank you so much for watching today's session, and I hope everyone has a great day.